Needed and still water?
Definitely.
Yes.
Okay, thanks. Oh, I can see it. Okay, I got a thumbs up. So today's neurocognitive disorders. These primarily involve memory and learning issues. As individuals live longer, baby boomers age, this becomes more and more an important part of our nursing care. In addition to memory and learning, it can involve loss of orientation. So when we ask them those orientation questions, person, place, time, situation, they may not know the answers to those. Their ability to pay attention declines. It affects decision making. Emotions. Language. And psychomotor function. When we talk about these, some of them are reversible, most of them are not. Length can vary from delirium, which is usually a short-term situation, to very long-term dementias. I think when we talk about Alzheimer's, some research shows 10 years or more from the time that they first start to exhibit symptoms till their death. Sometimes one of the important things we'll talk about in the beginning is being able to differentiate between the two. It does get a little bit confusing because sometimes, especially in older adults, you'll have the two together. So you'll have a delirium from some sort of acute situation superimposed on top of a dementia that's a long-term situation. Nurses should always remember that cognitive losses are not a normal physiological change of aging. So regardless of the age of your client, if they're losing cognitive function, we need to investigate that. Find out if there's a cause that we can treat. So first we're going to talk about delirium and how we can separate it from dementia. Both are neurocognitive disorders. They're vastly different in terms of length and prognosis. So, delirium is a dramatic, acute behavioral changes. It can be likened to when Mr. Berry talks about the difference between respiratory failure or respiratory distress and those things. This can be likened to brain failure, basically. This is an acute brain failure. Unlike dementia, which can begin suddenly, this is a dramatic one. Delirium usually begins rapidly and is really noticeable when it happens. Although it still gets overlooked and undiagnosed sometimes because we confuse it with dementia in those populations. What kinds of things can cause it? Medical conditions. This is especially true in the elderly. Things like UTI, pneumonias, MIs, or even electrolyte imbalances. Some medications can cause it. I have a list of a few here, but I'm not stressed out about you writing them down. You don't have to memorize these for the test, but just know to be looking at medicines that could cause this in your clients. The ones I have written down are antidepressants, cogentin, and anticholinergics, but you don't have to necessarily memorize that. In addition, you need to look at your clients for polypharmacy situations, especially in older adults. Lots of chronic conditions, lots of meds, decreased ability to metabolize and eliminate those, so that can be a cause too of delirium. Intoxication or withdrawal from a substance can cause a delirium. And exposure to other sorts of toxins can cause deliriums. And then there's kind of just other etiology. One example is ICU psychosis is a form of delirium. So like clients who are in the ICU will sometimes develop the symptoms of a delirium. So speaking of that, what does delirium look like? So the hallmark characteristic that differentiates it from dementia is, once again, the sudden onset. Clients may, rather than a steady decline, they may have a fluctuating LOC. So their level of consciousness may fluctuate rapidly. We talked about orientation. Clients may become disoriented in their delirium. You may also note that they have slurred speech. The most important distinction in there for you guys to remember is the sudden onset, basically. As dementia is typically slow changes, which it takes us a while to notice. A delirium, typically a person changes rapidly from where they were just a few days ago. You've got 3 types on your next slide. Hyperactive, hypoactive, and mixed. Not necessarily things that you have to memorize, just that you recognize that there are different types. So a hyperactive client is going to look like what you would think of. They're restless, they're agitated, they're jumpy. Lots of activity. They may become combative even. They may be suffering from delusions or hallucinations along with that. On the other end of the spectrum, you may have the hypoactive clients. They may be drowsy, sedated, tired, slow to move, slow to answer your questions. And then mixed clients are going to have characteristics of both. Makes sense that we are better at diagnosing the hyperactive ones. We notice the ones that are restless and agitated and suffering from those sensory perception issues. The hypoactive ones are a little harder for us to pick up that they're in a delirium without those active symptoms. What do we do about delirium? The first thing we want to, so assessment-wise, we want to assess for safety issues, and we want to find the physical cause of it. We talked about delirium can often be a first sign of a medical condition. I kind of think maybe even in your COPD lecture, Mr. Baird talked about that in terms of pneumonia, that a delirium can sometimes be in older adults, a first symptom that you see in a pneumonia. You want to be sure you check their prescription and their OTC meds. As far as OTC meds, specifically cough syrups, any kind of supplements that they're taking. Yeah. Well, the phone isn't working here still. You're fine. And then also things that they might take for pain or allergies or sedation could cause it. So things like Benadryl can be contributing factors to delirium. So those are the kind of things you're going to assess for in their medical history. As far as treating it, it is an acute emergency. It indicates to us a major decline in their health for some reason. So our treatments are basically keeping them safe while they're in a state of delirium and treating whatever the underlying physical cause of the delirium is. That's it for delirium. That's a quick one. Does anybody have any questions on that far so far? Okay. So we're going to move into what's major neurocognitive disorder, formerly called dementia. And you'll kind of see that term in some of these slides in and out too. So what is major neurocognitive disorder? It involves progressive deterioration. So unlike delirium, it's a progressive slow deterioration. And then you've got a list on your slides that kind of tells you what areas deteriorate. We talked about this a little before. Deterioration in memory, cognition, perception, language, behavior, affect, and motor abilities. We can only diagnose someone with dementia if we've eliminated all those possible things that could be a delirium. Basically, that's the only way that we can decide they really have a dementia, is if we've made sure that they don't have any of those other things going on that could be just a delirium. And I've got that note on here again, that cognitive disorders are not a normal effect of aging, so you gotta investigate those. And the reason is that early identification equals early treatment and improves outcomes. Maybe not outcomes, but at least the path that they take through the disorder. One of the ways, and some of them, we'll talk about a lot of different kinds. Alzheimer's is a common one that most of us know of. There are some other kinds. There is some genetic component to a lot of them. So genetic testing can give us an early identification. That we'll talk about this more, but that has its pluses and its minuses. Sometimes it's good to know and be able to watch for, but then it also, can feel like a death sentence to people that will change the way they live their lives if they know that that's in their future. There is no cure for most causes of dementia. Current treatments, for the most part, just slow progression, especially with Alzheimer's, which is the most prevalent one. The eventual progression continues, but it kind of will help decrease the symptoms as you're going along. Symptoms are considered mild neurocognitive when they're limited to just forgetfulness and don't interfere with ADL function. Major neurocognitive involves substantial decline and interferes with their ADL abilities. And once again, since treatments are just going to slow progression, we really want to catch them early because it's going to allow them to extend their independence the earlier we start treating them, since all we can do is slow it down and we can't really stop it. So once they've lost function, for the most part, they're not going to get that back, even with treatment. Different types. So first one, the most prominent one, accounts for 50 to 80% of dementia cases, is Alzheimer's. The name Alzheimer's comes from the doctor who originally identified kind of the characteristic pieces that we see from it, which is, and you don't need to remember this, but beta amyloid plaques and neurofibrillary tangles are the things that we look for this disorder. Specifically, can last up to 10 years. It was first named in 1907 by Dr. Alzheimer. Risk factors. Age is the most significant risk factor. We typically see it in people who are older as they age. And we're going to talk about some chromosomal things because it's important for you to know that it has that genetic component. You don't have to memorize these chromosome numbers that I'm going to give you, but some people with Alzheimer's have a particular piece of chromosome on chromosome 19 that shows us a predisposition for that. Having a history of a head injury can also predispose us to Alzheimer's, but we'll talk about a more common type of dementia that comes with head injuries too. And then having a family history either of Alzheimer's itself or any kind of cardiovascular disease history in your family can predispose, can be a risk factor. There's a newer staging system that has 7 stages, and that's where those numbers come from on your slide, and we'll kind of go through and describe those. So stage 1 is no decline. No decline, so their function is not declined yet. And this may be, Alyssa, do you have a book in front of you? Is it spelled out? What page is that? Okay, that's what I have in here. So on page 333 is where it spells out these stages. Stage 2 is very mild cognitive decline. These people may have difficulty finding words, forget the names of items, or where they left things. Stage 3 moves on to mild decline. So they're going to start having trouble with kind of problem solving, maybe at work or going to new places. Sometimes having trouble with new experiences, new problems, and more complex thoughts. Stage 4 is moderate decline. They're going to have even more trouble with complex tasks such as financial issues, or if they're trying to plan a large gathering, they're going to struggle with those things. Stage 5 is when it starts to affect their ADLs. So they're going to have to be reminded now that they need to brush their teeth or they need to groom. Stage 6 is severe decline. They're going to now need assistance with those basic ADLs. So not only will they need to be reminded, they're going to need help in bathing and brushing their teeth and things like that. This includes toileting, and this is the stage where incontinence tends to develop in these clients. Stage 7 is very severe impairment. These people are unable to walk or sit. They're no longer ambulatory. They may lose their ability to smile. Their communication is going to decline. They may not speak at all, or they may use only very few words to communicate with others. At this stage, their intake is likely going to be limited to liquid or pureed foods because they can't chew and feed themselves anymore. The next slide talks about some of the assessments that go along with Alzheimer's. The first one is the Montreal Cognitive Assessment, and basically it involves, and you don't have to write all these things down, but the client has to follow certain directions, like they have to draw a clock and put a certain time on it, or they have to count back from 100, or things that will require kind of that short-term memory to be able to do them, or spatial cognitive skills, things like that. So just some simple instructions, or naming animals, because remember they're going to lose that ability to name common objects. Lab testing, we want to look for thyroid or nutrient deficiencies that could be contributing factors that can help us eliminate whether it's a delirium or dementia. MRIs and CTs, similar function, that helps us eliminate things such as cancer, strokes, other sources that might be causing the symptoms. Also, spinal taps or PET scans can help us rule out possible other disorders. So for the most part, these things are not, those kind of things are not necessarily diagnostic, but we're ruling out other things that might be causing problems. In terms of future research, there are some markers that we can find in cerebrospinal fluid, but what we found is sometimes people who have them don't develop Alzheimer's either, so it doesn't kind of totally explain the picture to us, why some people do and some people don't. I think I have a note about this later, there's an interesting study about nuns, well, let's get to it, about a big group of nuns who volunteered to participate in a cognitive function study, basically. And it was interesting because, and then they all, I think, had autopsies when they died, and what they found is that the number of like those neurofibrillary tangles and amyloid plaques and things didn't necessarily equate to their decline in function. Like some of them would have a lot, but have a mild decline in function. Some of them had a lot of loss of function and not as many plaques. So it's just kind of telling us we don't totally understand what contributes. They also found that sometimes people who were involved in more cognitive pursuits, like teaching and things like that, things where they were regularly learning, that offered a little bit of protection from the cognitive decline as they age too. So, some interesting thoughts about it. There is some genotyping that you can do, but you don't necessarily have to remember that for the test group. So what causes our actual symptoms in here? Like I said, we don't totally understand this. Lots of possible contributory causes. We know about our plaques and our tangles that were part of the original description, but like I said, we don't know, and we don't know if those cause the disease or they're caused by the disease even. We lose neuronal function, and there's some specific areas we lose it in, and it makes sense with the symptoms that we see, and that's the reason it's kind of important, is we lose it in, you guys caught up, cerebral cortex is one place. And the cerebral cortex is responsible for like the higher brain processes, more complex thinking and things like that. We lose it in the hippocampus. And those are involved in learning and memory. We'll touch on this later, but keeping in mind that these clients can't learn new information. So even when their long-term memory is still intact, their short-term memory is often starting to decline. So when you're doing discharge teaching and things like that, it'll be important to teach other people that are their support people as well, because they're not really going to be able to keep that new information you give them. It also affects the amygdala, which is AMYGDALA. This is where, one more time, yeah, AMYGDALA. This is where we get the emotional effects of it because it's part of the limbic system. It affects the forebrain. Forebrain, like F-O-R-E, like forehead, begins like forehead. And that affects motor control and some of the autonomic systems in the body. So that's where you can start to get the motor symptoms that we get. Not really worried about you knowing that much about the tangles and plaques, except that they exist, and it's kind of what the discovery that led to naming it. All of these things contribute to an atrophy, so actually we see an actual decrease in brain mass, sometimes in over half in clients who've had Alzheimer's for a long time. Genetically, there are a couple of different kinds with different genetic profiles. There's an early onset and a late onset type. People with early onset usually are diagnosed in their 50s or earlier even, and that one has a faster course. It's heavily inheritable. So if one parent has a marker from it, the child has a 50% chance of developing it. And those markers are found on 3 specific chromosomes, but you don't need to memorize those. The late onset type has that allele we talked about on chromosome 19 that increases the risk, but we also see clients who get it without any genetic background. So that's why we're saying we don't totally understand what leads to it. Hormones, the reason hormones is on there is there's some theory that says that maybe sex hormones that are developed early in life provide some protection from the development of Alzheimer's, and that's why we see it more as the sex hormones decline. So some debate about whether like taking estrogen supplements as a female will help protect some from it or not, but there's not a lot of good evidence to tell us either way at this point. There's some other, yes?
Is it more men than women or more women than men, or does it matter? Is there any difference?
I don't know the answer to that. It didn't point anything out about that. There are some other disorders it did.
Then we'll just guess that there's not.
I can look it up and find out. Yeah, off the top of my head, I do not know the answer to that. Unless one of you guys does.
Maybe since we can live longer, you might see a few more women, but I'll bet that's
Right, but it might be just related to numbers, not necessarily an actual, yeah. That may be true. There's also some studies that indicate a link between heavy metals and brain inflammation that precedes it, like aluminum and mercury, like higher intakes of aluminum and mercury. But once again, we don't really have, like, it's kind of connected, but we don't have any definitive research on that specifically. What do we see? What do these clients look like? They have memory loss. This is usually the first thing that we see in these clients. Typically, long-term memory remains intact in the beginning, and we see it more in the short-term memory. One of the reasons you assess that when you do your MSA on people. You check out when you ask them about what they have for breakfast or kind of something along those lines to check out their short-term memory. Clients will often regress to a previous period of time. I have a friend whose dad passed away in the last few months from Alzheimer's, and he was older, but his took a very quick rapid progression, and when they would go to visit him, he would want to know where their mom was. Well, their mom died when she was like 28, and she's my age. And like where he'd ask, where were you and your sister all night? You know, why were you guys out all night? You know, and they're both grown women with families of their own. So, go ahead. I think you would have to, I think even when we say rapid progression with Alzheimer's, we're talking not 10 years, we're talking a couple of years, you know, so you still, not as rapid as delirium, basically. And that's why you have to look for, eliminate all those other causes that could be delirium is to get that diagnosis at all. But I just mean more rapid than he didn't live for 10 years after he was diagnosed. But good question. In the final stages, your clients may regress so far they feel like kids and call out for their own parents. We'll talk about this a little more. Because they regress to previous stages, it's common for them not to remember loved ones who are deceased. So they may expect visits from people who have passed away years and years ago because they don't remember that part of life at this point. Difficulty finding words. This is one of the easier ones for us as medical professionals to spot early on, even in short-term interactions with our clients. We can sometimes look at that by showing them common objects like a paperclip or something like that they may not be able to remember what it's called, something that normally most people would know what the name is for it, and they can't remember the name anymore for it or remember what you use it for. We'll talk later about this. That becomes an issue too as far as safety, because they may not reach a point where they can no longer distinguish cleaning materials from juice that they would drink with breakfast, basically. And so you have to start thinking about safety issues like you would with young children who don't know those things yet. So safety is a major issue. Receptive aphasia. We're going to talk more on the next slide about that. We talked a little about difficulty concentrating. That may be shown in a client who can no longer follow a conversation. They can't follow the plot of a book or movie. Things that used to interest them, maybe they can't. Like if they can't read anymore because they can't remember what was going on from when they read the other day. If they have hobbies that require concentration, they may lose interest in those because they just can't concentrate for that long anymore. And that's a vicious cycle because the less they're using their brain, the faster they're going to decline. They may misinterpret their environment, so they may have hallucinations. Generally, those are visual or auditory. Oftentimes, they involve deceased relatives because they going along with the regression. They may also have delusions, although they tend to be more reality-based than the ones we see in schizophrenia, so not necessarily grandeur. I don't know what I'm doing wrong. I can get electrified for a word. Like the light won't come on at all. Yes. No, it's me. That's why it's a problem, it won't work. Here. Yeah, and then it's the right cord. Yeah, I'll let you play with it while we're going. So their delusions may involve feeling like somebody stole things from them, or that they're deceased relatives are alive. I didn't unplug it. Okay. Illusions. Illusions tend to indicate worsening disease, and they occur in almost all clients. It's kind of like what we talked about in schizophrenia, so there is some stimuli. Okay. Thank you. Yeah, the phone is messed up in here. It still doesn't work. They specifically might also involve animation of an inanimate object. So I think we see this sometimes. I don't know, was it the nursing home? Not this year that we went to before. Like there was a lady who had a doll with her all the time, and for her that was a baby, and that was, you know, she focused on that baby, but it made her very happy and entertained her to have that. And we'll talk about that later. There's a slide that talks about the fact that they basically only have the here and now, the present. So, you know, those things that kind of give them comfort and peace in the present are things we're going to focus on. We're not going to worry about straightening her out and telling her that that's not a real baby, that's just a doll, because she's going to forget that again in 3 minutes, basically. So if that brings her pleasure and comfort, I mean, that's on one of the slides. They very much live in the now. So our care for them is very much how can we give them peace and comfort in the now, rather than working out long-term issues or anything like that. So. Somatic preoccupations, obviously that's kind of, we talked about the somatic and another thing, involves preoccupation with physical symptoms, may or may not be founded ones. And they may also have trouble finding the correct words to express themselves. Thank you. Misidentification involves using the wrong names for people. This is often very devastating for family members and very hard on them. So you want to kind of give them a heads up that it's coming before the first time they walk in and they get called something else. And you think about if they're regressing generationally, and often people from different generations will resemble each other, then it makes sense that, you know, somebody may come in and get called by their uncle's name, or, you know, a deceased brother's name, or just different things like that. And so kind of, but it also, you know, imagine yourself how hard it would be if you walked in to visit your mom and she didn't remember who you were, or she confused you with your sister, or, so, you know, that's a big one for families in helping them cope. Sundowning is a behavioral change that occurs pretty predictably in a 24-hour cycle. Most people, this is at dusk. So some clients will undergo a major personality change and cognitive decline kind of around supper time every night as it starts to get dark. That's why it's called sundowning. It doesn't have to be at that time of day, but that's most commonly the time of day that people will experience it. It's very common, occurs in about 20% of people with Alzheimer's. And then as the disease progresses, they'll be unable to care for themselves. Incontinence of bowel and bladder in particular are really draining on families that are trying to care for their family members at home. So they will forget that they just went to the bathroom, they'll have a lot of incontinent episodes, and it just becomes a real, when your family can't sleep, it's very hard for them to continue taking care of the family member. So that's oftentimes the reason why. One of the things that will eventually push them for inpatient care. This one is the 4 A's of Alzheimer's. The first one, some of these we talked about in other lectures. I don't remember whether we've ever talked about this before, but it's the word for the things that we were talking about, like they can't identify or know how to use familiar objects. So agnosia. And in order to qualify as agnosia, it means it's not related to sensory impairment. So it's not that they can't tell us it's a paperclip because they can't see it well enough to tell us it's a paperclip. It's they can see it and they still don't know what to call it or how to use it. This applies to people in the naming situation. Some of the things your book talks about are covering pictures or mirrors if the client is distressed by the things that they see. So remembering that if they've regressed, they're not going to know this old person who's looking at them in the mirror because they regressed to a previous stage, or they may see pictures of family members and they can't remember who they are, or they can't remember their name. So if those things are stressing your clients out, you can remove those, cover those, do something else with them if they're causing distress for your person. We talked about removing dangerous objects, choking hazards. They may get medications confused, so you're gonna have to limit access to medications when they get to that level. Cleaning supplies and even toiletries, things that you might, like perfumes and things like that, could be harmful if they forget what they're for. Aphasia is the next one. There are two types, but they often occur together. Expressive is difficulty expressing oneself, basically. So expressive aphasia is when I can't say what I'm trying to say. Not for a physical reason, but because my brain can't come up with the word that I need to say. Receptive is when I have difficulty understanding what's being said to me. Once again, we want to first check sensory issues, make sure that it's not related to a hearing issue that we can fix for them, that that's not why they're having trouble communicating. And we want to use our tone and our nonverbal communication to improve communication with these clients. Help them find the words when possible. What we'll talk about later, don't rush them or finish their sentences for them because they need to be able to express themselves in that moment too. When you're communicating with them, you want to use simple step-by-step instructions. So you can't give them a long list of, okay, do this, do this, do this, and then do this, because they're not going to make it all the way through that list. So one step at a time when you give instructions to them. Amnesia. This is the inability to recall previously learned information or to learn new information. We want to be sure that we don't test the client's memory, and we want to teach our families not to do that either. They don't want to put a picture of a loved one in their face and push them to remember that person's name. I mean, if they're not capable of remembering the person's name, they're not capable of it. And it's just frustrating for them and upsetting for everyone to push those things. So they're not going to remember what you told them. You can't go into the room and say, remember, we talked about this, because they don't. So we have to understand it. We have to educate families to understand it. Then we talked about a little bit, we need to compensate for that loss in judgment. So not only physical safety concerns, but also financial safety becomes an issue sometimes for these clients. They can become victims of scams easily. And then it's also an issue with education. When we educate, we need to make sure we're educating support people too. We want to give them things that are in writing or pictures or different things like that to go along with it in the education. Apraxia is the inability to carry out their motor activities that is not related to their motor function. So kind of like with the other ones we talked about, not recognizing something but not due to visual function. This one is motor function, but not due to the fact that their muscles won't do it, it's that their brain can't send the right signals for it to happen. Okay, any questions about Alzheimer's from the stuff that we went over so far? So we're gonna look at some other kinds of dementia that are the less common ones. Okay, go ahead, Henry. Yes, lecture capture is on since he was in here. Something was unplugged and he plugged it in and he has it going now. Okay, so first one is vascular. So we make